Mic test. 1, 2, 3, mic test.
Good afternoon, everyone. We'll start in 5 minutes. Pam, with your permission.
Hello, Doc. Let's just wait for a couple of we are missing two of our panelists.
Okay, okay,
Sorry.
okay. Thank you po. Hello, good evening everyone.
Evening,
Doctor.
good evening to all.
Good evening po, sir. With your permission, can we start?
Yes.
Doctor.
Okay. Good evening, everyone. Welcome to the very first of 2025 Head and Neck Interhospital Grand Rounds, which is spearheaded by the Academy for Head and Neck Oncology of the Philippines, Visayas contingent, in cooperation with Philippine Society of Otolaryngology-Head and Neck Surgery. And also, we'd like to welcome our non-ENT colleagues who are present online. Welcome po kayo, sir and ma'am. I am Dr. Maria Nieto H. Lucero Jr., IN for short. I am your moderator for tonight. Let's open our program with the Philippine National Anthem, followed by an invocation and PSOH and his hymn.
Bayang magiliw, perlas na silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, tuyat ka ng mag-ibig, sa manlulupi, di ka pasisiin. Sa dagat at bundok, sa simoy at sa langit mong bakaw, kay dilagang tula at awit sa paglayang minamahal. Ang kisat ng watawat mo'y tagumpay na nagtiningning, ang bituin at araw niya kailan pa may di magdidinig. Lupa ng araw na at ipagsinta, buhay langit sa piling mo. Aming ligaya ng pagmay mga api, ang mga day ng dahil sa'yo.
Heavenly Father, we come to you today with humble hearts, seeking your guidance and wisdom as we begin this program. Lord, we ask that you would bless every person who has gathered here today, and that you would be present with us in a special way. We pray that this program would be a time of learning, growth, and fellowship for all of us. Help us to listen to one another with open hearts and open minds, and to support one another as we strive to serve you in all that we do. Please give us the strength and the courage to follow your will, and to use the gifts and talents you have given us to make a positive difference in the world. We pray all of this in your holy name. Amen.
Buhayin ang pag-asa natin, sikaping maabot ang bighiin. Ilatag ang daan ng bukas, tulong-tulong magbigay ng lunas. Handa ihayag ang pangako, at ito'y ating isa puso. Yakapin ang adhikain, karamdaman ay pawiin. Halina't magkapit-bisig, sa sikap at panunuri, ang sigaw sa lahat ipariwati. Sulong na sa kinabukasan, tumulong pagtulad ng bayan, kalusugan ng bansa, maging layunin ng bawat isa. Halina't makapitisi sa sikap at panunuri ang ating sarili, tuklasin isang samahan, buuin natin ang PSOHNS, malakas matatag, mahalin natin, sabay tayo tumugon sa hamon ng panahon, at bukasiya natin dapat natin tuparin. Halina't magkapitisi sa sikap at panunuri ang ating sarili, tuklasin isang samahan, buuin natin ang PSOHNS, malakas matatag, mahalin natin ang PSOHNS, malakas matatag, mahalin natin.
Let's give the time to Dr. Muhammad Arif A. Bagondali, our very own PSO HNS President, for the welcome remarks.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Dr. Pauline Gadi, the chair of the Academy of the Head and Neck Surgery of the Philippines, Dr. Pamela Nicole Adrido, the course participants, residents, and members of the course, good morning. In behalf of PSOHNS, congratulations to this remarkable and important academic and scientific exercise. Let us continue to engage more in training development, such as interesting case reporting and research. It is a mandate of the PSOHNS to improve welfare, training, and scientific advancement of ORL-HNS in the Philippines. We need to achieve and excel in all academic and scientific endeavors. To the academies and the training institutions, continue to collaborate. Count a strong support from the society as we continue to commit to improving, enhancing, and advancing the specialty and subspecialty through various scientific exercises like this. Let's protect the society by closely working on its vision and mission to building a more relevant organization that drives innovations, collaboration, and excellence. We do all this, the very core of the organization, to explore more opportunities for the specialty. Important and unique clinical cases shall be documented for future references. Thank you to AHNOP for providing platform for this activity. Together, let's embark on making the society stronger by strengthening its vital armor, the training institution and the academies. Mabuhay ang AHNOP, mabuhay. Bismillah.
Thank you, Dr. Bagandali, for that very warm welcome. It is both an honor and pleasure to introduce our four esteemed panelists who are very outstanding in their field of expertise. I'm ecstatic to introduce first. Okay. Sorry. So he is a graduate of University of the Philippines, College of Medicine, class of 1984. Completed his residency training in Otolaryngology-Head and Neck Surgery in UPPGH in 1989. Became a clinical assistant and fellow in professorial unit at Institute of Laryngology and Otology for 1 year under Mr. David Howard, and became an immediate past chairman of the Department of ORL-HNS East Avenue Medical Center in 2017 to January 2025. My pleasure and honor to introduce our first panelist, my PACFAR's mentor and boss, Dr. Armando M. Chong Jr. Sir.
Thank you, Dr. Nieto, for that very
Sir.
kind introduction.
Sir.
And of course, thank you to AHNOP under Dr. Pao Gadi for inviting me as a panelist for some specific cases, especially on plastic reconstructive cases. And also to PAM, also for inviting me personally for this particular activity. Thank you.
Thank you, sir. Our second panelist is a graduate of University of the Philippines, Manila College of Medicine, class of 1995, completed her residency training in Otolaryngology-Head and Neck Surgery at UPPGH in 2000, done his post-residency fellowship training in clinical preceptorship and research fellowship in Head and Neck Surgery Division, Memorial Sloan Kettering Cancer Center, New York, USA in 2002, and also her clinical fellowship in head and neck reconstructive microsurgery in Changgang Memorial Hospital in Taiwan in 2005. A round of applause to Dr. Janet Marie S. Matsuo. Ma'am, good evening po. Our third panelist is the bright and humble, graduated in Cebu Institute of Medicine, class of 1993, residency training internal medicine in UPPGH in 1997, and medical oncology in the same institution, graduated in 1999. And he is a past president of Philippine Society of Medical Oncology in 2020 and 2021. A warm welcome, Dr. Buenaventura C. Ramos, Jr.
Good evening, everyone, and thank you for this invitation.
Our last but not the least panelist, graduated in the University of the Philippines, Manila College of Medicine in 2008, and done his residency training in Otolaryngology-Head and Neck Surgery at UPPGH, graduated in 2013, and Radiation Oncology, Department of Radiology, UPPGH. He is double board certified in head and neck surgery and radiation oncology. Let's welcome Dr. Cesar Vincent L. Villafuerte III. Sir.
Good evening.
Good evening. Okay, let's proceed to the first case by Dr. Catherine S. Iligan from Eastern Visayas Medical Center.
Just
She will
we will be giving 7 minutes. The presentation will usually last for 7 minutes, and 20 minutes will be allotted after each presentation for the panel discussion.
Good evening, doctors. I'm Katrina Silagan, oral HNS resident of EVMC. So for our interhospital grand rounds presentation, we have the following objectives: to present and manage a case of salivary giant cell tumor, to discuss management of possible recurrence. We are presented with patient SG, 68 years old male from Naval Biliran, with a chief complaint of left submandibular mass. 10 months prior to admission, left submandibular mass noted measuring 2 by 2 centimeters in size. No other associated symptoms, no consult done, no medications taken. In the interim, gradual enlargement of left submandibular mass noted, no associated symptoms, no consult done, no medications taken. 6 months prior to admission, gradual enlargement of left submandibular mass, consulted with private MD at Biliran Leyte, referred to an ENT specialist, FNA biopsy done which revealed a chronic granulomatous inflammation. Patient was lost to follow-up. 5 months prior to admission, gradual enlargement of left submandibular mass, now measuring 6 by 5 by 3 centimeters, consulted at ORLH and EVMC OPD for the first time with an initial impression of left submandibular gland malignancy. Neck ultrasound requested, which revealed left submandibular mass, benign versus malignant neoplasm histopathologic correlation is recommended. Right supraclavicular mass with benign features for which a lipoma is primarily considered. Incision biopsy was done, which revealed giant cell-rich tumor. Considerations include, but not limited to, giant cell tumor and giant cell granuloma. IHC requested, which revealed giant cell tumor of the bone. Patient was lost to follow-up. In the interim, gradual enlargement of left submandibular mass noted, no associated symptoms, no causal done. 6 days prior to admission, enlargement of left submandibular mass, now measuring 10 by 10 by 9 centimeter, painless, movable. Presented during specialty clinic, plan was for excision under GA. Patient was advised for admission. Past medical history, patient is hypertensive, maintained on losartan 50 milligrams tab once a day. Family history, unremarkable. Personal social history, patient is a college graduate who is a retired government employee, non-smoker, occasional alcoholic beverage drinker. On physical examination, the patient was examined awake, alert, oriented to time and place, and not in cardiorespiratory distress with stable vital signs. Pathologic examination as well as rhinoscopic examination were both unremarkable. Oral cavity examination, hard and tender movable mass at floor of the mouth left was noted. Head and neck examination, trachea deviated to the right, 12 by 10 by 9 centimeter, firm, multilobulated, non-tender, fixed left submandibular mass with skin induration. Admitting diagnosis of left submandibular mass to consider giant cell tumor versus submandibular gland malignancy. On CT scan, soft tissue window, sagittal, axial, and coronal cuts, a large lobulated enhancing isodense mass with areas of non-enhancement that may represent necrosis seen in the left submandibular region, measuring 6.9 by 6.1 by 6.6 centimeters, which occupies the submandibular, sublingual, and carotid space. Mass effect is seen as right deviation of the trachea, and surrounding lymph nodes are seen with largest, measuring 1.3 by 0.7 by 1 centimeter. Bone window, axial, and coronal, no bone involvement noted. We have a final diagnosis of left submandibular mass to consider giant cell tumor versus submandibular gland malignancy. For the plan, excision with 1 cm margin of the skin involvement with MRND left with reconstruction using cervicopectoral advancement flap under GA. These are the intraoperative pictures. On the right, 12 by 10 by 10 firm multilobulated left submandibular mass with skin induration. The photo on the left, the mass together with levels 1A and 1B, as well as cervical lymph nodes left removed. Cervicopectoral advancement flap done, Jackson Pratt drain placed, wound closure done. So the specimen together with the lymph nodes left. On microscopic examination, reveals a well-defined lesion consisting of mononuclear cells with prominent mitotic activity. Interspersed with short spindle cells and osteoclast-like giant cells, which exhibit no significant atypia. Additionally, areas of hemorrhage and cystic changes are observed, consistent with secondary aneurysmal bone cyst alterations, along with evidence of necrosis. Giant cell tumors, primary giant cell tumors, first described by Eusebio et al. In 1984. Due to rarity, there is an absence of literature that has analyzed GCTP. All published material has been case reports. Generally considered as a benign tumor originating from the bone, extraosseous GCTs have been reported in a number of organs, temporomandibular joint, larynx, maxillary sinus, and other soft tissues. Giant cell tumor of soft tissue, locally aggressive mesenchymal neoplasm of intermediate malignancy that predominantly occurs in superficial soft tissue of the extremities, belongs to fibrocystic group, and etiology is unknown. Giant cell tumors of the visceral organs usually contain a carcinomatous component and are clinically more aggressive. Average age of 59 and 57% of tumors contain a carcinomatous portion, either salivary duct carcinoma or carcinoma X pleomorphic adenoma. They have similar histomorphological features to giant cell tumor of the bone. However, they have contrasting characteristics, which are as follows. Strong association with carcinoma, biological aggressiveness, lacks peripheral reactive bone formation, commonly admixed with mononuclear component, decreased mitotic activity. Histologically similar to giant cell tumor of the bone and may be genetically different. Lacks H33A gene mutations that are identified in the vast majority of GCTB. Immunohistochemically diffusely positive for vimentin, CD68, and negative for cytokeratin, epithelial membrane antigen S100, HMB45. Basic treatment is extensive resection. Radiotherapy is highly effective for local regional control, however, is controversial. Combined radiation therapy is recommended if surgery is contraindicated, if surgical margins have not been achieved, if diagnosed with an associated carcinomatous component. This is our patient on first follow-up with well-completed wound. However, on third post-op follow-up, mandibular mass noted 1 by 2 by 1 centimeter and posterior auricular mass also noted 1 by 1 by 1 centimeter soft non-tender removable mass. Patient underwent excision biopsy and we're still waiting for the final histopath for this specimen. These are my references. Thank you and good evening.
Thank you for that thorough presentation, Dr. Ilagan. Any reactions or comments from our esteemed panelists po, or from the online audience? If you have question.
I have a question,
Yes po, ma'am.
Dr. Matsuo. Was there mention of the margins on final histopath?
Good evening po, Doc.
Just go ahead, Dr.
Negative margins po aside from the deep margin po, Doc, positive.
When you say deep margin, where is that? On the neck or on the floor of mouth?
Neck po, Doc.
Sige, so sa floor of mouth, even without removing the floor of the mouth mucosa, negative ang margin doon?
Yes po, Doc.
Okay. So it was positive margins there or close margins lang? Positive. Positive margins.
Positive for deep po, Doc.
Sige.
Deep margin.
Okay. So when you say giant cell tumor of the soft tissues, is the salivary glands included in the soft tissue category?
Yes po, Doc.
Sige. So what we know mostly is giant cell tumor of bone, diba? So as you said, this is very rare, no? Actually, this is the first time I am encountering a GCT of soft tissue, usually kasi bone. So I was wondering when I was reading the abstract, how come the mandible was spared, no? There was no bony involvement on CT scan, no? So we are dealing here with a very rare tumor. And majority of cases will be benign. Correct? Tama ba, Dr. Ilagan? From your references, most of them will be benign, but there is skin induration. No, but aside from that, were there other aggressive features, both on physical exam, CT, and intra-op? Madikit ba? No, aside from the skin induration, no, were there other aggressive features of this tumor? The lymph nodes are benign, di ba?
Yes po, Doc. We had a hard time dissecting po the
okay, so madikit.
The tumor itself. Yes po, Doc.
Madikit, no? Sige. But on histopath, no lymphovascular invasion, correct?
None po, Doc, so far.
No? And lymph nodes are negative, no? And the mandible is spared, no? So is this salivary gland GCT? What is this?
Yes po,
or
Doc.
Submandibular gland?
Yes po, Doc. Giant cell tumor unifocal, yung final histopath po, Doc, yung yung final.
Sige.
Yung excision biopsy po, Doc, we're waiting for that pa, Doc.
Okay. And then now the problem is the recurrence. No, there are 2 points of recurrences. No, would you say the recurrences are along the periphery of the resection margins? The one on the mandibular, pwede, di ba? But the one on the post-auricular, medyo malayo pa? Or umabot dun yung flap mo?
Yung flap po, Doc,
Umabot sa
umabot sa
post-auricular,
posterior
no?
auricular. Yes po, Doc.
Sige. So, sige. And you remove those? With margins ba? Did you get margins also? When you did the excision biopsies of those 2 recurrence points?
I wasn't able to do margins po, Doc, kasi it was very friable.
Oh. Okay, but you removed
Yes
skin
po, Doc.
also?
Yes po, Doc.
Okay. Sige. No more questions.
Thank you po, Doc.
Thank you, Dr. Amaso. Any question from our panelists or anyone from online?
I have a question. Do you think radiation therapy or adjuvant radiation therapy would have a role after you excise the first time, showing that your tumor is actually quite high grade with 25 mitotic figures per 10 high power fields?
According to my readings po, Doc, there's not much guarantee that it will not recur. Ito.
Hi, Dr. Ramos. This is Dr. Villaferte. I'm the radiation oncologist in the panel. And I actually have to echo the points raised by Dr. Ilaga. And if you review the literature, the role of radiation for GCT is controversial. So the more common entity would be GCT of the bone, and we reserve, and as Dr. Matsu has pointed out, this tends to be a benign tumor, but it can have a metastatic potential and of also malignant conversion. We do have guidelines for these, and we reserve radiation for unresectable disease, those which may be recurrent. So this case might actually benefit from adjuvant radiation therapy, but we tend to be a last line treatment. I may think Dr. Ramos can also share the role of rank L inhibitors, denosumab, in GCTs, but there are some retrospective single institutional series which showed about an 80% local control rate with the use of adjuvant radiation therapy for GCT. But in terms of the sequence of when it will be delivered, we tend to be a last line treatment. So we wait first if for example, for this case, although we have a positive margin, is that margin then still re-resectable? Can we still go after that margin to come up with an R0 resection? If not, and if are there other options such as denosumab? And if in the final event that there are no other options, we can offer radiation therapy. The guidelines recommend at least greater than 45 gray. The NCCN pushes it up to 50 to 60 gray. So that's the role of radiation for GCTs. Thank you very much.
Thank you, Dr. Villaferte. Dr. Ramos, can you unmute yourself, Doc? You're muted.
No. It's Dr. Matsu was raising her hand.
Okay, Dr. Matsu. Can you unmute Dr. Okay, Doc.
Dr. Ilagan, did you do a repeat imaging? Now that you're suspecting a recurrence, did you do repeat imaging? You have positive margins on the deep you have positive margins on the deeper area. No, for all we know, this might just be the tip of the iceberg, no? So did you do imaging to fully evaluate the extent of recurrence?
We only did neck ultrasound po, Doc, post-op. And then
Uh,
after the neck ultrasound, we did the excision biopsy po, Doc.
And what does the ultrasound say? Do you think ultrasound is enough?
We'll repeat the CT scan po, Doc.
No, I'm asking you. No, what do you think? I might be. I'm not saying that you should do a repeat CT scan, no, but do you think a CT scan is indicated in this situation?
Based on my readings, wala po ko, Doc, na nabasa.
Sige. On your physical
Yes,
exam,
po,
the
On physical exam, yes,
recurrent
po, Doc.
masses seem to be well defined.
Yes po, Doc.
Okay. Sige. Sige. No more questions.
Thank you, Doc.
Just excuse me.
Okay, go ahead, Doc. Dr.
Yes,
Chong.
I just want to comment on the reconstructive option. Can you show this is anyway just to start, if you have, can you show the reconstructive defect, please? The defect, the actual defect of the patient.
Sorry. Wait a second. Reconstruction in the video.
Silagan. Specialty space. What MRB as well as cervical lymph nodes left.
Anyway,
Do you have another picture, Dr. Ilagan?
yes, because we cannot see the actual defect. After this picture, maybe you could have established the skin flaps again, and you can appreciate the defect. You don't have any actual picture for the benefit of the listeners. Oh, ito na yung picture.
I have a picture po too.
Anyway, sige, hanapin mo. Anyway, the dictum really is to, if you have such a defect like this, the best reconstructive option is primary closure if you can. If you can close it primarily and it is very acceptable, so be it. In cases where you cannot close it, then you might as well look for a flap that is adjacent to the defect. That was being used here, that is near the defect. Pwedeng adjacent, pwedeng near the defect, but out of reach yung mga distal flap. So can you show me the defect?
For 11.
Okay, thank you. So they can really appreciate this particular defect. No, there's no way that you can really close it primarily. So the next option is to look for a flap that is adjacent to the defect, but that particular thin neck skin flap has to go. Kasi nga, mukhang redundant siya, so that you can rotate a flap adjacent to the defect. Now, the options here is a random flap. I agree with the reconstructive option of using a cervico-pectoral flap in this particular case. An option is a flap which has an axial blood supply, which is a deltopectoral flap. So it will be a judgment call for the surgeon. Pareho naman pwede. Kanya lang, the deltopectoral flap is more reliable because of its axial blood supply. That is the internal mammary perforators. But there will be no argument. Kung ako ito, pwede ko rin namang gamitin ang cervico-pectoral flap or may modification of a cervico-delto-pectoral flap. Can you show the slide?
Dr. Ilagan, can you please stop screen sharing for a while? Okay.
So I have searched this particular picture to show you an option versus a cervicopectoral flap that was being chosen in this particular case. The books will tell us that this is a cervicothoracic flap. Ang cervicothoracic flap, sabi nila, is synonymous for a cervicodeltopectoral flap. So ito yung design. My modification will be like this. Ito yung actual patient. This is a patient from Philippine General Hospital. I understand that this was referred to me few months ago. You have a cheek defect or a preauricular defect as big as like this. Now, I always ask the resident to design their flap. So itong left side, you can appreciate of course, the learnings of that particular resident. Okay naman talaga. This is a cervicodeltopectoral flap. Cervicodelto kasi in-encompass mo yung deltoid area. Now, if you encompass the deltoid area, that will have more blood supplies for that particular random flap, aside from the neck vessels. You have blood supplies from the internal mammary preparators of the deltopectoral flap, some skin blood supplies from the thoracoacromial arteries, and of course, blood supply from the deltoid region, naming the musculoperforators of the deltoid area. So pag in-encompass mo yung cervicodeltopectoral flap, mas richer yung blood supply. Ngayon, you can see on my right side, yung aking incision, lahat ng incision ko nasa gilid. And this is what I always teach the fellows and residents at PGH, na gawin nating modified para lahat ng incision, lahat sa gilid. So that is the incision of the resident. You can compare, pareho naman kami, hanggang sa deltoid area. Kanya lang, below the axilla, in-encompass ko yung groove ng breast. And the lower limb will be the crease of the lower breast. So that cosmetically, it will be more acceptable. So yun lang naman yung naging modification ko. Otherwise, kasi kung cervicopectoral flap, you can see ito yung end result, okay? All this scar will be on the side of the patient. Ngayon, can you compare the picture of your actual patient for the benefit of the audience? I don't say that your proposal is incorrect. Talagang tama naman. But cosmetically, kung magawa naman ng paraan na lahat ng scar will be hidden, so much the better. So can you show me your end result as compared to my end result?
Dr. Ilagan, if it's okay, can you do the sharing? Thank you.
So you can see, ito yung scar mo, kahit na ba elderly siya or ano man, kahit na elderly male or female, siyempre hindi basta makakahubad yan. That you can see an obvious scar on the anterior chest. Now, my modification, it will be, yun na nga, encompass mo yung the deltoid area, then design the whole deltoid going to the crease of the axilla, then you design it inferiorly up to the crease of the breast. So at least cosmetically, it will be more acceptable. But of course, this flap will survive like the cervicodeltopectoral flap. So that is my inputs in this particular case. Unless you have any questions. Minodify ko lang, ito kasing case nyo, you chose the cervicopectoral flap, which is talagang ito yon. Yung akin is a cervicodeltopectoral deltopectoral flap, a modification of the cervicothoracic flap, as you have seen from the diagram taken from a book. Cosmetic lang naman ang aking hinabol. And of course, a richer blood supply because you have to encompass the musculocutaneous perforators around the deltoid area. Dito kasi kinat mo yung deltoid region. Hindi ko naman sinabing it will not survive. But for a richer blood supply, sama mo na yung deltoid area. That's why it will be called a cervicodeltopectoral flap. I hope you understand what I'm trying to emphasize.
Noted po, sir. Thank you po.
Thank you, Dr. Ilagan.
Thank you, Dr. Chong, for that
Thank you.
input. For the interest of time, we have one more question to Dr. Buenaventura Ramos. Is there any rule for chemo for this case? Sir?
No rule for chemo for this case. Dr. Villaferte already mentioned the rank ligand inhibitor, which is denosumab. For this patient, if the recurrence is resectable, there's still no rule. Its role will come in when it's unresectable or if there's a metastatic disease.
Okay. Thank you, Doc. Thank you. We'll proceed to the second case. The second case. The second case is invasive melanoma, stage 4. The presenter is Dr. Jason Clement Asibuki from Western Visayas Medical Center.
Good evening, doctors. I am Jason Clement Asibuke, a Level 2 ORL HNS resident of Western Visayas Medical Center, and we are presented with a case of patient PJ, a 32-year-old female, single, from Iloilo City, who came in for a left facial mass. History revealed that patient was born with a left facial nevus, and 1 year prior to consult, patient noted a gradual enlargement of said nevus, now associated with irregular borders, reddish discoloration, and nodular growth. Due to the changes on her nevus, she sought consult at our outpatient department, where a wedge biopsy of the mass was done, confirming melanoma. Our patient has no known comorbidities and denies any previous admissions nor surgeries. Family history was unremarkable for any head and neck malignancies, and patient previously works as a street vendor with chronic sun exposure. Patient is a non-alcoholic and non-smoker. Pertinent physical examination findings revealed a 14 by 19 mm flat, reddish-brownish lesion with a central 5 by 5 mm raised nodule at the left infraorbital to buccal area with no intraoral extensions. No cervical lymphadenopathies were appreciated. Initial preoperative workup revealed a 1.8 by 0.9 by 1.5 cm soft tissue lesion along the skin at the left cheek with a very small portion protruding into the superficial subcutaneous soft tissues, but with otherwise no deep component. Patient was subsequently appraised admission for surgical management and underwent wide excision, superficial parotidectomy left, selective neck dissection left levels 1 to 3, and reconstruction of defect using cervicofacial flap with the following specimens removed. Final tissue biopsy revealed invasive melanoma, superficial spreading subtype with Breslow depth of 1 cm and negative for tumor involvement, all surgical margins, parotid, and lymph nodes. In the interim, patient was apparently well, and on 5th month post-op, patient was noted to have a well-coaptated surgical wound and flap with no palpable masses appreciated. Metastatic workups and lactate dehydrogenase were requested with unremarkable findings as well. Patient was referred to our cancer center and underwent 6 sessions of systemic chemotherapy with dacarbazine, and on 6th post-operative month follow-up with medical oncology, a pimple-like lesion was seen above the previous surgical site. However, patient was appraised for observation. At 7th post-operative month, the assumed pimple increased in size and follow-up was done at our clinic, and patient was seen with a 2.5 by 1.5 centimeter firm nodular subcutaneous mass that is non-tender and movable at the infraorbital area. Fine needle aspiration biopsy of the mass was done, revealing atypical cells suspicious for malignancy. Repeat preoperative neck CT scan was requested, revealing an interval appearance of a minimally enhancing mixed solid cystic mass in the left malar region, measuring approximately 2.4 by 1.6 by 1.6 centimeters, compatible with tumor recurrence. Patient then underwent a second major operation of wide excision, frozen section, reconstruction using lateral forehead flap, and split thickness skin grafting with a 5 by 6 centimeter specimen removed. Final histopathology results revealed invasive melanoma, negative for lymphovascular invasion, and negative for tumor, all surgical margins. On the 18th day post-operative follow-up, a 6 by 6 millimeter pigmented mass at the wound edges of the inferior portion of the recipient site was noted. She then underwent a third procedure of flap amputation, wide excision, frozen section, and split thickness skin grafting, wherein at post-operative day 16th, multiple subcutaneous blue-black lesions were seen at the left preauricular area. Final histopathology results were still consistent with invasive melanoma, breast hole depth 7 mm, with microsatellite lesions noted, and negative for tumor, all surgical margins. Metastatic workup with chest and whole abdomen CT revealed multiple non-calcified nodules in both lungs, compatible with metastasis, as well as hepatic masses compatible with metastasis. Thus, patient currently managed as a case of invasive melanoma of the left cheek, stage 4, RT4B, N3C, M1C0, status post wide excision, frozen section, superficial paroidectomy left, neck dissection left, levels 1 to 3, reconstruction using cervicofacial flap, status post escharotomy left, facial area, status post chemotherapy with the carbazine for 6 cycles, status post repeat wide excision, frozen section, reconstruction using lateral forehead flap, split thickness skin grafting, status post amputation of forehead flap, repeat wide excision, frozen section, split thickness skin grafting. NCCN dictates a multi-stage guideline for managing melanoma, and for patients already presenting with distant metastasis, initial metastatic workup should be done, which, for a patient, revealed pulmonary and hepatic metastasis on CT with a normal lactate dehydrogenase. A multidisciplinary conference was conducted with medical oncology, radio-oncology, general surgery, family medicine, and radiology, wherein it was agreed that the best option for now is systemic chemotherapy with paclitaxel and temozolomide, as well as palliative care. Our patient, however, is currently lost to follow-up. Thank you, everyone, for listening.
Thank you, Dr. Asiboke, for that presentation. Any reaction and comments from our esteemed panelists?
Can I start na, Dr. Cero?
Yes, po, ma'am. Go ahead, ma'am.
I have a question for Dr. Asiboke. What were your margins during the initial surgery? We are dealing here with a cutaneous melanoma, no, which is different from mucosal melanoma. Huh? So this is for the residents in the room. This is cutaneous melanoma. What was your planned margins of resection during the initial surgery?
For the initial surgery, the planned margins were roughly 2 centimeters.
Okay, so that's wide enough, no? 2 centimeters all around. And your histopath showed negative margins. All margins of resection were negative, correct? No. So And even in the subsequent re-excisions, no, all margins were negative, even on frozen section and finally stopath. No, so unfortunately for this patient, no, every now and then we get these kinds of whatever you do, they still recur. My question is for Dr. Vinci. No, is radiation indicated here? Especially during the first surgery. After the first surgery, only chemo was given.
So let's step back now kasi now we're metastatic disease. So I agree with the vital multidisciplinary plan where systemic treatment should be the backbone of our treatment. But going back to the patient's course, they showed the NCCN guidelines for cutaneous melanoma, radiation therapy is a category 2B recommendation. However, we do see multiple risk factors present in this case. I think the first surgery, they mentioned the breast low thickness of 1 centimeter. Was that correct, Dr. Sebuke? So we know anytime there's a breast low thickness greater than 4 millimeters, that's already a risk factor for recurrence. They actually specify that the head and neck site is another risk, just being in the head and neck site as being a risk factor for local recurrence. Neurotropism would be something else we would want to look for in the histopathologic report. And the margin status, as Dr. Amatsu had mentioned, the pathologic margin status would also be a consideration. So, I would have opened the discussion for adjuvant radiation therapy after the initial surgery. The discussion on why it's a category 2B recommendation is because there can be some cosmetic defects, especially these are usually cutaneous lesions, diba? So that's why it isn't, they have to balance out the risk benefit ratio of the adjuvant treatment. But hindsight is always 2020, you know. Maybe this patient could have benefited from aggressive treatment during the first surgery. That's my general comment.
Thank you, Doc. What about the rule of chemotherapy? Is it enough, Doc? You only use they only use the carbazine for Dr. Ramos after the first surgery.
I also don't know why. Perhaps the finances or Dr. Arsibuke?
For initial chemotherapy, doc, currently we do not have any available immunotherapy agents at our institution. And yes, the medical oncology opted for the available dacarbazine.
Okay, yeah. So ideally, for this patient at this point, we would test for BRAF, and then if it's positive, then there are specific medicines first choice for BRAF, unless sometimes because the medicines for the BRAF positive tumors are also not available in the Philippines. So and they're quite expensive. So if you think you're not considering treatment for BRAF directed therapy anyway, so you may not test it. And then the next would be immunotherapy. It's ideally for the BRAF negative, but in case you don't have treatment for against BRAF directed, you can use immunotherapy, and the available immunotherapy in the country is pembrolizumab. So especially at this point, I because you didn't mention that immunotherapy is considered or things like that. You just mentioned paclitaxel and this, and what's the other one that you're considering? So I may not consider chemotherapy, especially that you already exposed the patient to the carbazine, which is another chemotherapy, and it didn't work. So as much as possible, try to aim for the immunotherapy. Pembrolizumab, it's available. It's the patient assistance program, although the patient assistance program, the least would still be quite expensive. It's like 70,000 per month. Yeah, but then if you cannot, then yeah, a paclitaxel and temozolomide will be a choice.
Thank you, Doc. one more question for Dr. Chong. Do you agree with Doc, sir? The first they did cervical facial in the first recon, then after that they do the lateral forehead. Then the
Can you
patient is
show? Yeah.
female.
Yes, that is a very good question, Dr. Nieto. Can you show us the first few slides wherein you use the cervical facial flap? So anyway, ano yung from this particular picture, hanggang saan yung anterior, yung pinaka-inferior limb mo? Yung pinaka-inferior na yan, hanggang saan yan? Kasi from the neck scar of the patient, medyo mataas yung naging scar eh. Bandang gitna ba yan ng leeg?
Midline, Doc.
Who did this particular design?
One of our senior.
I agree with the anterior incision from the lateral side of the eye, preauricular area, below the ear, at the back of the ear. Up to what extent yung inferior limb incision mo? Kasi may particular landmark yan to maximize the vascular territories using the cervical facial flap. Hindi, gusto ko lang malaman kasi wala ako sa actual case. Ano yung pinaka-lower limb incision mo? Ano naging boundary mo?
For the lower.
Yes, yung lower limb. Hanggang saan umabot yan? Yung pinakamababang incision mo.
Just aligned with the skin crease present in the neck of the patient.
Skin crease of the
neck, Doc.
Wait lang nga, nawala yung earphone. So it's skin crease of the neck. So anyway, I just want to clarify. Can you show a actual patient have done at PGH? So ito pala, naka-show ba ito? Okay. So this particular patient, this was done at PGH few months ago. That is the particular defect. You can see my design. After removing the defect, my inferior limb incision will encompass almost always at the edge of the clavicle. So hindi ko maklarify sa iyo kung anong neck skin crease yun. So anyway, ang aking design, I will encompass the whole anterolateral neck area. Ang pinaka-endpoint ko inferiorly will be above the clavicle just to encompass the whole anterolateral neck skin area for better blood supply. I presented this in a webinar at East Avenue last year, this particular case. And our mentor, Dr. Guevara, has commented on me na medyo ayaw niya yung design ko. Because ang kanyang modification, the inferior limb will be below the clavicle. Sa kanya, mas below the clavicle, yung inferior limb for cosmetic purposes. I think that is logical kasi ito, kita mo pa rin yung scar. If your inferior limb will be designed below the clavicle, that particular inferior limb scar will be hidden. So I think the more experienced Dr. Guevara, I learned from him in this particular case. So anyway, Hindi ko alam kung medyo nasa midline ng neck skin crease yung inferior limb mo, that will not encompass the whole neck area. So, mas limited yung blood supply mo ng cervicofacial flap. Kanya siguro nagka-problema, but we really don't know kung ano naging problema. Medyo nagka-problema yung case, yung flap na yon, karoon ng congestion at whatever. So I don't know bakit. Niisip ko lang baka isang reason is the design. You have limited your design of the inferior limb on the midline of the neck skin crease of the neck area. Kumbaga, nasa gitna ka lang ng leeg. Maaabot yung rotation, but of course, we want to maximize the cervicofacial flap. And my design, on my particular side, you can see and appreciate, I have encompassed the whole neck skin area. Ang naging modification lang ni Dr. Guevara, yung inferior limb incision will be below the clavicle. And next time, I will do that. Lahat ng aking incision will be below the clavicle for cosmetic purposes. Unless you have any comments or questions. Now, regarding the question of Dr. Nieto, yung second question mo, of using the forehead flap.
Yes po.
Can you show me the actual flap harvesting, the actual slide?
Sorry, Dr. Asibuca, do you have it?
And of course, the particular defect para all of the listeners can appreciate what we're talking about. Okay. Regarding the question of Dr. Nieto, do I agree using this particular flap as a second option because of the defect like this? I think I will also make use of this because there's no way that the delta pectoral flap will reach that particular area unless nga mag-free flap tayo with the combination of IL and of course Almelor. There's no question about it. I will make use of this, the lateral island forehead flap, as an option for this particular defect because it has an axial blood supply using the superficial temporal vessels. Now, ang aking modification lang dito, as I've emphasized during my teaching among the portiers in PGH and of course the fellows, the pappers and head and neck, I will always make use of my upper incision at the edge of the hairline. At the edge of the hairline. Sa taas. Mismo sa edge. Yung sa baba naman, at the edge of the eyebrow. For cosmetic purposes. Kahit pa paano na-hide mo yung scar. That is my modification. Maybe you will not agree, but that is my modification. If I will make use of a lateral island forehead flap.
Thank
and
you,
of
sir.
course, Dr. Pam et al., they have learned a lot for this particular lateral island forehead flap because they have harvested the STSG for the distal 1/3 of the forehead defect. In-harvest nila, nilagay nila. After, at the time of amputation, after 2 to 3 weeks, that particular STSG has healed already. So by the time you amputate and put back the remaining flap, the anterior distal third of the forehead defect na may STSG has healed already. So it will minimize the hospital stay of the patient. Harvesting the STSG on the first operation, and after amputation, nag-healed na yung graft. So this is the end result. So by the time you amputate, healed na yung STSG. So Dr. Pam and of course Dr. Nieto from the Visayas, I am very happy that you have absorbed the learnings of using the forehead flap, a lateral island, for so many cases. Thank you.
Thank you, sir.
Thank you.
So with the interest of time again, can we proceed to the third case? There's no more question. The third case is a case of anaplastic thyroid carcinoma, stage
Good afternoon,
4B.
doctors. My name
Okay, go ahead.
is Marisa Fenetrelli, a resident from the Corazon Luxin, Montiliban Memorial Regional Hospital. We are presented with patient PO, a 63-year-old male from Bacolod City, with a chief complaint of anterior neck mass. History revealed that 2 months prior, there was a sudden onset of anterior neck mass, 2 by 2 cm, firm, fixed, non-tender, and moves with deglutition. There was a noted mass effect like dysphagia, dyspnea, or hoarseness. No consult done and no medications taken. In the interim, there was persistent increase in size of anterior neck mass, still no consult done. However, 1 month prior to consult, there was a persistent increase in size of anterior neck mass, consult done with an endocrinologist. Neck ultrasound and FTAB was done, revealing findings consistent with anaplastic thyroid carcinoma. Patient was eventually referred to ENT specialist for further management. 1 week prior, consulted with an ENT specialist, and the patient was then advised admission for further workups. For the past medical history, patient had a history of hypertension and DM type 1 with the following maintenance medications. No known food or drug allergies and no previous hospitalizations or surgeries. Family history revealed a paternal side history of diabetes mellitus and goiter. No history of hypertension and cardiac diseases. Patient is a non-smoker, an occasional alcoholic beverage drinker, and no illicit drug use. Review of systems revealed no noted hoarseness, dysphagia, and no dyspnea, and also no palpitations. Other systems were unremarkable. Physical exam of this patient was seen awake, not in cardiopulmonary distress, with stable vital signs and no noted hoarseness or stridor. For the head and neck exam, notable is a 11 by 9 cm firm, non-tender, mobile anterior neck mass which moves through deglutition. Also, there was a confluence of cervical lymphadenopathies on the level 3 to 4 on the left, measuring 7 by 9 cm. Skin is taut with no erythema nor skin involvement. There was also a palpable sternal notch. Shoson-Lang findings were also unremarkable. This is the profile picture of the patient. As for the diagnostics, neck ultrasound was done last March 3, 2025, which reveals a normal size right thyroid lobe. However, for the left thyroid, it is enlarged, measuring about 11.5 by 4.6 by 6.9 centimeters. It was replaced with the following nodules. For the upper, there is a noted heterogeneous hypocoaxial nodule with coarse calcification, measuring 5.6 by 4.5 by 4.3 centimeters, classified as CRS 5. For the lower and the lateral part of the left thyroid lobe, there is a noted hypoechoic nodule measuring 5.1 by 3.9 by 3.2 centimeters and 6.3 by 4.8 by 3.9 centimeters, classified as CRS 4. FNAB was done last March 7, 2025, which revealed a Bethesda category 6 malignant, which is consistent with anaplastic thyroid carcinoma. Upon admission, the following laboratories were done to this patient with TSH, SGPT and SGOT revealed normal within the normal range, however, a slight increase in FT4. Also, on admission, Web ultrasound was sent to this patient revealing mild fatty liver, prostatomegaly with concretions, sonographically normal biliary tree and gallbladder, spleen, kidneys, and urinary bladder. Chest X-ray was also done, which revealed no significant lung findings. Next CT scan with contrast was also done to this patient. As for the representative cuts, this is the most superior extent of the mass at the level of C4, the vertebra, with a traceable common carotid artery at the level C3, C4 of the vertebra. Also a noted enlarged left thyroid gland with replaced by a heterogeneous mass with peripheral calcifications measuring 5.5 by 5 by 6.7 centimeters. Also a large confluent heterogeneous left cervical lymphadenopathies, which on the level 3 and 4, which measure 7.2 by 7.7 by 8.9 centimeters. This is the representative cut on the mid portion of the mass, as it is seen posteriorly to be in close relationship with the esophagus, however noted to have a good plane. The left cervical lymphadenopathies encases the left common carotid artery and is inseparable with the left thyroid mass. Also noted tracheal deviation to the right. For the most inferior part, which extends at the level of C7 to T1 of the vertebra, with a traceable proximal carotid artery at the level of C7 to T1 vertebra. Also a rough cut of the bone window, which noted to be the erosion at the posterior part of the left heart cartilage, and also noted a tracheal deviation to the right with mild tracheal compression. So the impression for this patient is anaplastic thyroid carcinoma, stage 4B, T4B, and 1A, clinically M0. That's it for the presentation, doctors. Thank you and God bless.
Thank you, Dr. Torelia, for the presentation. Any reaction and comment from our panelists?
I have a question to the historian. So patient is Dr. Torilla. Patient no compression symptoms yet? Dysphagia, dyspnea?
Yes po, doctor.
Wala pa.
Wala pa po.
And the patient is pre-op. No, the previous kasi post-op na eh. This one is pre-op, no? So what was your initial plan after the imaging and the metastatic workup? Is this resectable?
This was contemplated, doctor, to do a total thyroidectomy with neck dissection po, doctor. And after the contemplated OR po, maybe a referral to rad onco, doctor, and
So
chemotherapy.
you're planning for surgery. No, you'll try to remove this one. On your physical exam, I noticed that your palpation is firm. Firm lang siya, hindi pa siya hard, correct?
Opo, doc, opo.
And it's still movable?
Opo, opo.
No? Sige. And your CT scan, March 24, resectable pa, except for the close adherence to the esophagus. What about the encasement of the carotid? How much encases the carotid artery?
This was confirmed with radiology po, doctor. 180-degree po na encasement po.
Oh, okay. No, so you plan to do surgery, siguro at the very least, the debulking, no? If you cannot remove everything, at least a debulking, I think that will help, no? So, and a neck dissection. Okay, no, but because of the close association with the esophagus, no, how will you address that, the close adherence to the esophagus during surgery?
We can insert an NGT po, doc, to know po if there is we can palpate the NGT para mas madali po natin mahanap yung plane po.
You don't want to damage, no, the esophagus. Okay. No more questions.
Thank you po.
Thank you, Doc. I have a question for Dr. Vinci. What role does radiation therapy play in this case po? And how is it used in combination with other therapies?
So, actually, we do have several guidelines for this now. There's the US ATA, there's updated NCCN, and even though the local guidelines are titled well-differentiated thyroid cancer, the DOH guidelines actually touch on anaplastic thyroid carcinoma. And the role of radiation therapies for the non-metastatic anaplastic thyroid CAs increases local regional control. But I agree with the plan of Dr. Torilla. If surgery can be incorporated in the trimodality treatment of this case, it would be the best possible outcome for our patient. Although we know that for anaplastic thyroid carcinoma, the prognosis is very guarded. If the patient will not undergo the total thyroidectomy and neck dissection, we will consider if Dr. Ramos and the medical oncologist would still consider neoadjuvant treatment, converting this to become a resectable case, or upfront radiation therapy with chemotherapy, just to provide local control, especially if there's already impending potential airway compromise. So that's it. Thank you.
Thank you, Doc. For Dr. Ramos, what about chemotherapy, Doc?
So if this is resected, so I would work with a doctor, with the radiation oncologist after. May consider concurrent chemoradiotherapy. If this is unresectable, if not doing surgery, then we can. It's similar to what I have mentioned with melanoma, the BRAF testing, and then give the medicines to address the BRAF mutation. If you can afford it, we can actually order from Singapore, but it's really very expensive. So if not, then if you cannot afford that, and also if it's BRAF negative, then you can also again immunotherapy with or without a tyrosine kinase inhibitor together with the immunotherapy, or work with the radiation oncologist together with radiation therapy and a concurrent chemotherapy.
Thank you, Doc. Is it available here in the Philippines or in Visayas? The BRAF testing?
Yeah. We send our specimen to NextGen. It's here in Cebu, but they send to Detoxicare, which is in Manila, and it costs something like 14,000.
Okay. Thank you, Doc. Questions?
I have a
Go
question
ahead, Doc.
again for Dr.
Yes, Doc.
Torilla, no? Dr. Torilla, when do you plan to do a tracheostomy in this case? A prophylactic tracheostomy. Will you?
If there is an aggressive increase in size of the mass, doctor, we can opt to do a elective na tracheostomy insertion po. Especially if the patient presented with a mass effect na po, doc, na dyspneic na, doc. You can do elective tracheostomy for this patient.
During surgery, no? So let's say you went and did surgery, you did debulking at the very least, no? Will you still do a tracheostomy?
If there is noted po na tracheomalacia, doctor, we can do a tracheostomy po intraop, doc. If there is intraoperatively, especially if meron na pong part ng trachea po na weakened na po by the mass.
Correct.
We can do a tracheostomy.
Okay, thank you.
Thank you, Dr. Matsuo. Let's proceed to the last case. Already, if there's no more question. Case of what?
Good evening, everyone. I am Mary Grace Ramizo, a fourth-year ENT resident of Vicente Soto Memorial Medical Center. Tonight, I will be presenting a case entitled A Silent Space, a Growing Threat, Case of an Infratemporal Mass. This is patient JC, 55-year-old male, married, Filipino, Roman Catholic, a family driver from Zamboanga del Sur. Chief complaint of right preauricular mass. 9 months prior to consult, patient noted onset of progressive right preauricular pain upon mastication with pain scale 8/10. Self-medicated with herbal medicine without relief. condition was tolerated and no consult was done. 7 months prior to consult, noted persistence of symptoms associated with limitation of mouth opening and right preauricular swelling. Sought consult at a local hospital where ultrasound was done, revealing right parotitis with solitary lymphadenopathy. CT scan of the neck with contrast was also done, revealing a lobulated heterogeneously enhancing mass with calcifications, right masticator space, with lytic destruction of the right mandibular ramus and sclerotic changes in the mandibular condyle, likely neoplastic. At this point, patient was advised to biopsy, however refused and opted second opinion. 4 months prior to consult, patient noted persistence of symptoms with new onset headache with a pain scale of 7/10. Sought consult at our OPD, where ultrasound-guided FNAB revealed non-diagnostic results. Hence, incisional biopsy via gingivobuccal approach under local anesthesia was done, revealing fibrocartilaginous tissue fragments with focal atypia and areas of necrosis. Patient was then referred to the head and neck clinic and surgery was advised. Past medical history revealed no known comorbidities, no previous hospitalizations and surgeries with no allergies to food and medications. Family history was unremarkable. Patient was a non-smoker and an alcoholic beverage drinker. Physical examination revealed a 5x5 cm non-erythematous firm fixed non-tender mass on the right preauricular area. There was also noted limitation of mouth opening with interincisal distance of 2 cm. No facial nerve paresis were noted. The rest of the systems were unremarkable. Here is the patient's incisional biopsy slides with the microscopic description of fragments of fibrocartilaginous tissue with focal atypia and areas of necrosis suggestive of chondroid neoplasm. The CT scan of the neck with contrast also revealed a 4.8 by 4.0 by 4.1 cm expansile heterogeneously enhancing soft tissue mass with necrotic areas and calcifications in the right masticator space, causing displacement of the adjacent muscles, mild effacement of the right parapharyngeal space, and thinning of the overlying cortex. Notably, the greater wing of the right sphenoid bone, right pterygoid notch, coronoid process of the right hemimandible, squamous portion of the right temporal portion, or right temporal bone, and posterior wall of the right maxillary sinus. A periosteal reaction in the condylar process of the right hemimandible is also observed. No evidence of cervical lymphadenopathies. So the planned procedure was excision of mass via zygomatical transmandibular approach with total parotidectomy right with facial nerve preservation, mandibulectomy right, application of titanium reconstruction plate with condylar prosthesis right, under general anesthesia. Here are the intraoperative photos. A modified Blair incision with coronal extension was made. After the skin flap elevation, we noted the preauricular mass with temporal fossa extension. Total parotidectomy was done. And here we can see the zygomatic arch. So we did 2 osteotomies on the arch to remove it and preserved it soaked in a saline solution. The superior lateral extent of the tumor was exposed. Mandibulectomy was done with osteotomy at the level of the ramus, 1 cm below the inferior extent of the mass. With blunt dissection, the mass was removed in a piecemeal fashion. Once the tumor was completely removed, titanium reconstruction plate with condylar prosthesis was applied, fixed with 3 titanium screws. Here's a photo of the specimen, the tumor and the mandible involved. Postoperatively, the patient was noted to have a right facial nerve paresis, House-Brackman grade 5. Noted improved mouth opening with 2.5 cm interincisal distance. On post-op day 3, patient developed postoperative delirium and was co-managed with psychiatric service. On post-op day 7, patient's symptoms improved and was subsequently discharged. After 10 days, the biopsy results came out and revealed A neoplasm with lobulated architecture composed predominantly of hyaline cartilage with relatively low cellularity. The neoplastic chondrocytes reside within the lacunae and display only minimal nuclear atypia with slight enlargement with mitotic figures are not identified. The tumor demonstrated an infiltrative growth pattern, permeating through adjacent bone trabeculae and soft tissue. Focal areas of myxoid change are present within the abundant chondroid matrix. Necrotic areas are not observed. This was signed out as chondrosarcoma stage 1. For the final diagnosis, chondrosarcoma of the condyle with infratemporal extension right, stage 1, T1 and 0 MX. Status post excision of mass via zygomatico-transmandibular approach with total parotidectomy right with facial nerve preservation, ramus mandibulectomy right, application of titanium reconstruction plate with condylar prosthesis right under general anesthesia. For the surveillance, patient was advised regular follow-up checkup every 6 months up to 5 years, then yearly for a minimum of 10 years, as clinically indicated. This will include physical exam and CT scan with contrast. Thank you so much and good evening, everyone.
Thank you, Dr. Ramiso. Any comments and questions from our panelists?
I have a question, Dr. Matsuo, for Dr. Ramiso.
Yes, Doc.
Do you think you have positive margins? Chondrosarcoma
In
kasi
this
is
case, Doc,
treated with
grossly we were able to remove it, Doc. However, microscopically, yes, Doc. Can you hear me, Doc?
medyo nagcha-choppy.
Hello, Doc. Yes,
Sige,
Doc.
it's clear now. It's clear now.
Can
I
you hear
did
me
not
now,
hear
Doc?
your question. Yes,
Yeah.
better now. I did not hear your answer. Do you think you have positive margins?
In this case, Doc, I would think microscopic. I cannot really assure that there is negative margin microscopically, but grossly we were able to remove it, Doc.
Okay, pero chondrosarcoma dapat wide margins of resection, no? But the location of your primary tumor precludes you from achieving that, no? So definitely assume that you have positive margins, no? So the next question is how will you address that microscopic, even if microscopically positive margins? What will be your next step? Kasi part of your plan is surveillance, if with recurrence, no? Definitely there will be a high risk of recurrence. So assume that and act now, no? So yun yung comment ko lang. So very good, no? You were able to remove everything, no, in a difficult area, no? That is very commendable, no? But right now your objective now is to address the potential risk of recurrence, because definitely you have microscopic positive margins.
Yes, Doc. There are journals I've read, Doc, regarding this case that we can do radiation therapy. However, there are also other journals that would say that chondrosarcomas are actually radio-resistant, especially the high-grade chondrosarcomas. So, in this case, what we plan, Doc, with my consultants, we plan to do a close follow-up monitoring in this patient. That is to do a CT scan. According to the NCC and IGCC guidelines, we can do it every 6 months. So that's what we're hoping at this point, Doc, to monitor for any recurrence through CT scan, Doc. And of course, physical examination.
So maybe we can ask, no, Dr. Villaferte and Dr. Ramos, for what would you recommend, no, to address this high risk of recurrence, local recurrence?
So I'll start na lang po. So I would agree na I'd do a slide review. I think we could get more information from the pathologic report. I think from the PowerPoint presentation, it was mentioned as a stage 1, but in the abstract that was sent to us, the grade was actually provided. It was a grade 1 disease. So this classifies as a low-grade chondrosarcoma. I would also look at the margin status, as Dr. Matsuo has mentioned. For low-grade chondrosarcoma, I agree the backbone of treatment is surgery. Pero we all know that the site where the tumor was located, it's difficult to get a good margin. So we are expecting that this patient probably has an R1 or potentially even an R2 resection margin. I would have wanted to have that documented in the pathologic report because I think your surveillance strategy right now, I would actually push for a closer interval. I think you mentioned about 6 months. Probably do an 8 to 12 week repeat imaging
Yes, like,
because if the backbone of treatment will be re-excision, catching it at a smaller stage or a smaller recurrent size might give better opportunity for re-excision. Now, if it comes to the point that it no longer becomes resectable, that's where radiation can play a role to provide additional local control. Pero as you've mentioned, for mesenchymal tumors, I wouldn't say naman na radio-resistant, but less radio-sensitive as compared to our usual SCCAs or lymphomas. But there can still be some additional local control that can be derived from external beam radiation therapy, especially if re-excision can no longer be done. Yeah, thank you.
thank you.
Okay, Doc. Doc Bell.
Yeah. So, as as mentioned by Dr. Villaferte, the protocol actually showed grade 1. You didn't mention that in your report, but the way the pathologist described the tumor is saying that it's quite low grade. So for low grade sarcomas, they are chemo resistant, so they don't really respond to chemo. And in your protocol, the protocol that you submitted, you actually placed there in case of recurrence, you would refer to internal medicines for radiation for radiation. I don't quite agree. If there's recurrence, first you assess the resectability and resect again. So especially that your tumor is low grade, it won't respond to chemotherapy, and the response to radiotherapy is, as mentioned by Dr. Wilfert, is also low if it's low grade.
This is noted, Doc. Thank you.
Thank you, Doc. Ma'am, I have a question for Dr. Matsuo. Doc,
Yes.
in retrospect, Doc, without because this case we don't have the definitive diagnosis yet prior to the definitive surgery. What will you do for this case? You will do repeat biopsy, or you do like frozen section intra-op or something just for the diagnosis?
A good thing you mentioned that, no? Isa sa mga naisip ko rin yan when I was reading the protocol, no? Why go in when you don't have a definitive diagnosis? So, if sometimes kasi it happens, you do a repeat or even a third biopsy and still inconclusive, no, or not very specific, then you proceed with your clinical impression, no, whether this is malignant or benign, and act accordingly, no. Pero for your specific question, I think I would have repeated the biopsy.
Okay.
Para during surgery, no, mahirap kasi yung puro intra-op decisions, no. Maganda before going in para yung counseling mo rin sa patient, your informed consent, no, very appropriate depending on the tumor that you are faced with. So yun, Dr. Nieto.
Thank you, ma'am. Thank you. Any question from our panelists? One more thing for Dr. Villafuerte, sir. I just want to ask, how will you mitigate or more or less avoid, because if we do, because this is near the skull base already, for the radiation, like to avoid, like such as like osteogeonecrosis, how will you give your radiation therapy, sir?
So we have more highly conformal techniques. The standard of care right now for head and neck tumors is intensity modulated radiation therapy, which aside from the beam direction, the intensity of each beamlet is already controlled. So that can help mitigate or decrease the dose to some of the surrounding areas, but it cannot completely eliminate that risk. So sometimes decisions have to be made on whether we want to give the full dose to a critical organ, which means there might be some increased morbidity, or we decrease it just to maintain to what's called tolerance, what the organ can tolerate. So that's a clinical decision. That's why this has to be hand in hand as well with the patient in terms of what their risk appetite is. But in general, what we want to do is to deliver as much dose as we can, because the worst morbidity actually is a recurrence. Because that means that the tumor will still grow and then it'll cause more problems. So, but again, that's a joint discussion with the patient.
Thank you, sir. One more thing, sir. For example, in retrospect, if we already know that it's already a chondrosarcoma, will you still recommend applying a reconstructive plate, or you want it bare bone, wala na?
Naman, the question has been often raised, no? Will the reconstruction plate cause significant problems for the radiation? With the modern techniques naman, we're able to account for yung the plates in terms of the radiation treatment plan. And there have been studies that show that it has some attenuation, pero minimal naman. And with the work of with our hand-in-hand work with our physicists, we can still compute or take into account the plates. So I wouldn't say that plates are a contraindication to adjuvant radiation treatment.
Okay. Thank you, sir. Any question from our panelists?
There's a question in the chat.
Okay. Okay, there's one question from Dr. Jose Roberto Claridad. He asked, if you had known the biopsy pre-op, would you still have gone for surgery outright or give chemo arterial first? This is for Dr. Ramizo or anyone from any.
Thank you for the question, Doc. Yes, Doc. If I had known this was a chondrosarcoma, I would still go with the surgery since it is the mainstay treatment. But I have to make sure to do a wide section, because that is important in this case. However, as mentioned, the mass has already extended superiorly up to the floor already of the middle cranial fossa. So that part would be probably difficult to get a negative margin. Yeah, but probably for the mandible and especially for the posterior wall of the maxillary sinus, I think that should be also removed as well to get a negative margin.
Okay, thank you, Dr. Ramizo. Any questions, po? So I think with the interest of time, let's move forward with the giving of certificates. So this is for Dr. Armando M. Chong Jr. Thank you for sharing. Dr. Armando M. Chong Jr. for sharing their invaluable time and expert opinion as a panelist in the quarterly head and neck interhospital grand rounds held in April 22, 2025 online via Zoom platform. Given this 22nd day of April 2025, signed by President of PSOHNS, Dr. Muhammad Arif A. Bagundali, and our very own AHNOP President, Dr. Pauline Gadi. And of course, our Inter-Hospital Grand Rounds Program Coordinator, Dr. Pamela Nicole Ladrido.
Thank you. Thank you so much for the invitation, and also to the Academy under Dr. Pagagi. Thank you.
Thank you, sir. Then the next for Dr. Jeanette Marie S. Matsuo. Thank you for your time, Doc.
Thank you.
Thank you. And also Dr. Buenaventura C. Ramos Jr. Doc, thank you for sharing your time with us and expertise. Thank you. And the last but not the least, Dr. Cesar Vincent L. Villafuerte III. Sir, thank you very much for being with us tonight and sharing your knowledge. Thank you.
Thank you as well. And I actually want to congratulate the teams that prepared. The cases were not the usual cases, so I think that was also a good learning jumping point for everyone. Thank you very much.
Yes. Thank you, Doc.
Doc Ian,
So,
hello. This is Pam. I am sorry I missed placing the certificates, but I would also like to thank the participants for taking the time to make your presentations and sharing your cases with us. Thank you.
thank you. So, to close the program tonight, we have our chair, AHNOP chair, Dr. Pauline M. Gadi, for her closing remarks.
Hello, good evening, everyone.
Good
So,
evening, Pao.
thank you. That was a very good discussion, and I'd like to express my sincerest congratulations and appreciation to the Visayas ANOP contingent, especially Dr. Pamela Ladrido, for hosting and organizing the first quarterly ANOP Interhospital Grand Rounds for 2025. So this kind of multidisciplinary interhospital grand rounds is important for us so that we can get to know the cases that we encounter in our part of the Philippines. And we hope that we can be able to continue this meeting within the academy, at least quarterly, no, moving forward. So we thank you to the Visayas contingent, no, for starting the ball rolling. So much appreciation also to our mother society, the PSOHNS, headed by Dr. Muhammad Arif Bagindali, for the never-ending support and guidance to the academy and its activities and advocacies. And of course, I'd like to thank the panelists who graciously accepted our invitations. Dr. Arman Chong. Hi, sir. Dr. Jen Matsuo. Hi,
Hi,
ma'am.
Pao.
Dr. Benaventura Ramos Jr., Dr. Vinci Villaferte, my batchmate. Thank you. Thank you for your contribution and insightful participation. So this your engagement and insights have made this event really valuable. Thank you also to the presenters for their participation and preparation of your cases. It's preparing cases for these kinds of activities is not an easy task, and thank you for that. Thank you also for all the participants who attended. So I believe this discussion has been informative for everyone, especially as Dr. Villaferte mentioned, these are not the usual cases that we see. These are kind of challenging, no? So I hope everyone found this activity beneficial. And before we close, I would like to join everyone. So this week is Head and Neck Cancer Consciousness Week. We still have several activities lined up in our own institutions and chapters. And also, we also have our virtual fun run, Takbo para sa Buhay. We've extended it to April 27. So everyone who wants to join can still register and do their own fun runs. No, may mga nag-submit na po na nag-fun run together. So we will be posting all of these updates in our Facebook page. So again, in behalf of ANOP, thank you very much for everyone's participation, and may we continually promote and advocate for head and neck cancer awareness together. So thank you very much. Thank you.
Can we have a photo shoot?
Yes, Pam?
Oh, photo shoot
Yes,
before we
sir.
go.
Everyone,
Sayang.
so we had 80 participants, but now just 60. I'm sorry to the YouTube viewers, you can't include you in the photo shoot, but everyone available, please turn on your turn on your cameras so we can all see you. Thank you for joining us tonight. I'm so glad we finished on time.
Congrats, Pam. It was a good discussion.
Okay, video 1, 2, 3, smile. Wait a sec. My God, capture. Okay. Next group, Dini, picture. And everyone who can turn on their cameras. Okay. Thank you. Okay, one last group. Okay, so that's all. Thank you so much again. Thank you to Dr. Ian Lucero, our super moderator.
Thank you,
Thank
Dr.
you.
Lucero. Thank you,
Thank you
Ma'am
po.
Jen. Thank you very much.
Thank you
Dr.
so
Arman
much.
And
Chong.
to our
Night.
consultants who are here, to the panelists, thank you so much.
See you next
Thank
Thank you,
week
Doc.
Bye,
Thank you.
Vinci.
sa Makati
Have
Med.
Bye,
Okay.
Pam. Thank you, everyone. Sir, Dr. Hi.
a
Erwin, I see you. See you, everyone.